Hi, good afternoon. My name is Leticia, and I will be talking about family-centered rounds. I did my clinicals at UCLA Pediatrics 6 Northwest, and this is for both Nursing 629 and Nursing 635. Okay, let's get started. I'm going to start off with the introduction. So UCLA Health, just so you guys know, specifically UCLA Pediatrics is a 25-bed unit with patients ranging from ages 0 to 21. The main project at hand was finding ways to improve parent involvement in the daily morning huddle, or more importantly, family-centered rounds. And for those who don't know, family-centered rounds are defined as interdisciplinary bedside rounds that actively engage the patient/family and involve them in shared decision-making with the understanding that the parent and families deserve open, honest, and unbiased communication regarding their health care. This way, parents can be aware and engage with the care and result in improving the outcome of their child's hospitalization. Okay, this is, again, what I mentioned about UCLA. We're going to go on to talk about Jean Watson and her change theory. She does have the theory of transpersonal caring, which I believe applies to the family-centered rounds. The nursing model states that nursing is concerned with promoting health, preventing illness, and caring for sick and restoring the health. This adds a humanistic approach to nursing, and caring is demonstrated with action in nursing. So that's a very important part of this theory, where you basically show that you care for your patients with action. It creates caring promotes growth and creates an environment of healing. And so that's definitely very important, especially with family-centered rounds. Okay. The nursing model states that nursing is concerned with promoting health, preventing illness, caring for the sick, and restoring health. It focuses on health promotion as well as the treatment of diseases. According to Watson, caring is central to nursing practice and promotes health better than a simple medical cure. She believes a holistic approach to healthcare is central to the practice of caring in nursing. By including family-centered rounds in the facility at UCLA, we are actively showing to the extent to which we care for our patients. We're willing to extend ourselves more and go the extra mile and create this environment for the parents and children to heal. So basically, by doing the family-centered rounds, we would be applying Jean Watson's theory by showing with our actions how much we care. With two fundamental pillars. So child wellness and indicator are very important because the more that parents are involved, those children with the more involved parents, that helps increase their overall wellness. And this is supported by a study by Heimberry et al. 2017 that emphasizes the importance of parent involvement in a child's care. The authors conducted a study correlating BMI of obese children and weight loss with the involvement of parents in their exercise and diet plan. So as you can see, this is definitely supported that the more parents are involved, the overall helps with child wellness, and as well as adherence to their plans. The study found that the weight loss was higher, over 2 kilograms, in those children with involved parents and helped increase their overall wellness. So it could also be an indicator to the likeliness of treatment plans to succeed. So that's why we'd like to increase the amount of parent involvement in these treatment plans, and overall with the adherence of that child's plan, because it'll help them in the long run, and it'll also be a good indicator of that success. And this is what I mentioned. This is the study by Heimberry et al. I'm going to move on to the EBP question. So the EBP question was in PCOT format, and it's going to be right here on the bottom. In pediatrics patients age 0 to 21 years old admitted to UCLA 6 Northwest, is it better for patient care, to pull parents into rounds in the morning versus leaving them in the patient's room? And does it affect overall patient outcome during their acute hospital stay? And I do want to define acute while we're at it, just to make the PCOT question a bit more specific. The National Council on Aging defines acute as a few days to a few weeks, and a few months to years would be chronic. So here we want to do acute. For this patient population, acute will be up to 8 weeks or 2 months in this hospital. It's easier to measure the outcomes of parent influence in a short-term stay than a long-term one, which is why I chose to focus on acute. In addition, Connecticut State official website states that acute care is more short-term and severe episodes that result in a hospital stay. I believe that the support of a parent can make a huge difference because the severity of the conditions, as opposed to those chronic conditions where care tends to be more dragged out and parents might not want to be involved, or maybe they were at first but not so much anymore. And so I really want to focus on those acute cases where these are very rare episodes or onset, so that we can see how much that parent involvement is helping. Okay, we're going to move on to the review of literature. Okay, and so I did mention the surveys, and I'm going to summarize here on the bottom 3 bullet points. What were the summary of those surveys? So out of the 23 participants, 86% said they were able to attend morning huddle and rounds for their child with the interprofessional team. Remember that we're focusing on the rounds here, not so much the huddle, although the goal is to get them involved with as much as we can. 100% of those parents who participated reported they felt comfortable asking and able to clarify their concerns with the team. 100% of those who participated said they wanted to continue participation, which is amazing. Comments from the parents included there was great collaboration and they felt that they were given adequate information from the doctor prior, did not need to join due to such good communication. And that's definitely what we want to hear. And the rounds would serve more as a supplemental and a platform for them to ask questions. Some comments that were not so positive were the parents were not able to identify who is the attending versus the charge nurse versus the bedside nurse. So like the parents said that everybody is just scrubs. They're all dressed alike. And so definitely that is one of the components that I saw needed to be fixed when I would implement the policy. And so the consensus overall, though, seemed that the more involved the parents were, the clearer the treatment was to everybody, all the parties involved, including the intercollaborative team, and the smoother the stay seemed to go. And here is the surveys that were collected. These are just the spreadsheet, but it's a questionnaire, and all the questions that were on the questionnaire have been inputted here. A lot of yes and no questions. Most of them are yes and no questions, and the boxes on the right are spaces for comments. If you like to zoom in and kind of check out what some of the parents said, but overall it has been summarized, and it was definitely a very good idea. The parents loved it. They supported it. There are some kinks to be worked out, and that will be shown in the policy change. Okay, we're going to move on to the summary of evidence. Some alternatives to these plans, which we saw would not be beneficial because of the studies we just went over, but we're going to go over the alternatives anyway. So the clinical staff, the first alternative to family-centered rounds would be the clinical staff taking over and not including the parents. At all, but as seen with Browning et al., there would be a vital piece of information missing in the cultural implications and family dynamics. So basically, we would just not take the family's culture into account. We don't ask the parents if there's any special thing that they do for their culture or if there's any routines that they follow. We don't take any of that into account. We just, follow the way that it's supposed to be according to the policy now. And we might have an important piece of information missing. Another alternative is to continue with the rounds the way that they have always been done without the families. And so similar to number one, but number one focuses more on the cultural competency side. But as shown with Meyer et al., the entire interdisciplinary team would suffer because the overall communication would decrease, leaving more room for mistakes. So as we see here, it would actually decrease the intercollaborate team's efficiency as supported with Meyer et al. If we don't involve the families, because the families keep the intercollaborate team more accountable. It also keeps questions more clear. Explanations over and over again help the team because it helps everybody be on the same page. So not including the families would not be a beneficial. The third alternative is the team involved can prioritize the plan of care for the patient and not bothering offering assurance and parental involvement. So not giving back that consistent assurance that providers usually do. But as shown with Belufi et al., this would only increase PTSD rates with parents and children, and similarly would not take the humanistic approach that was so emphasized by Gene Watson. So the most likely to succeed is the family-centered rounds because it has the best outcome for patients and the team involved. So it goes both ways, not just the parents, but the team as well. Okay, now we're going to go into the recommended practice, policy protocol, and practice change and implementation plan. So that would be the second part here. And what we would basically do is have the CNA remind each of their assigned clients of the day, basically assign a CNA to the same way you always would to their patients. And then they give reminders at the beginning of the day, hey, by the way, we're going to do rounds if you guys want to participate, right? And the previous shift can also do the same. So the CNA from the night before would also tell them. At rounds, the staff will give a name and role to each patient. And for patients with language barriers, language preference will be taken into account and a designated interpreter can be present at each round, and there's also going to be telemedicine available. Post-round surveys are the same thing that we've been doing. It's that spreadsheet that you guys saw, which is basically where the clinical nurse leader is collecting those or having their team collect them. Aim for 20 surveys a week. Right now, there is no aimed amount of surveys. I would change that and make it 20 a week. So how we would evaluate this plan. Okay, so I'm going to use it with important markers here, and we're going to go over that on this slide. So once surveys are collected from random parents every day or at least weekly for 3 months, we can determine the percentage of parents that felt assured in their child's care. So we're basically measuring the surveys here and involved in the treatment plan and knew what to expect in their child's stay. A score of 80% will be a good indicator that parents feel comfortable with the family-centered round process. And as you could see, from the 23 participants, 100 have all felt comfortable so far. So there's things to work out, but so far the surveys have been working. I would just like to do this with a more amount of surveys. As for the clinical side, statistics such as medical errors, patient medication compliance, patient parental refusal of treatment can also determine how well engagement affects care. A percentage of 80% or overall improvement to each category by 5% or more shows that family-centered rounds may be making an impact. The clinical nurse leader on site will collect this information and work with quality assurance to interpret the data. The plan should be on trial for 3 months, and if there's no change at all, then expand it to 6 months. And if there is no change noted within 6 months, the plan must be re-strategized. So basically, it would be on a pilot program for 3 to 6 months, depending on if there's change. If there is, then basically, if there is change and we notice that it's going really well, then we'll have it on trial or pilot for a year until more data is collected, and then it could be successfully implemented into the facility. So that is everything. Thank you so much for listening to me. I really appreciate it. Have a great rest of your week, your day. Thank you very much. My name is Leticia. My references.